Welcome to Alzheimer's MD Live. I'm William A. Van Horn, MD. I'm a medical doctor who has specialized in Alzheimer's for almost 20 years, worked with thousands of Alzheimer's patients, thousands of families. Tonight I'm answering a question from Liesel in South Africa. It's a really sad story. Her dad's only 71, and in 2016, he was diagnosed with Lewy body. I'm going to talk about the 4 cardinal features of Lewy body, and I'm also going to talk about the big picture of treatment. Now understand, when I talk about Liesel's father, I can't really tell you what the best treatment for him is. All I can do is to talk about the concepts. I'm not his doctor. I haven't evaluated him. I haven't seen him. It's not fair to his doctor to say his doctor's done anything wrong or right. But I can tell you what I would do in the big picture with Lewy body dementia. And in 2016, he was diagnosed with Lewy body because he was having visual hallucinations, some balance problems, some other issues. And he got progressively worse, and they've tried different medicines to get him under control. And now, since Christmas, around Christmas, he was not doing great, but markedly better than he is now, according to Liesel. Now he's in bed, basically bedridden, sleeping most of the day, and not doing well at all. And her question is there anything you would do differently? Again, I'm going to talk about what I would do. And I'll tell you what he's on and the medications and the groups and what I think about the groups of medications. As far as Lewy body dementia, the 4 cardinal features, and maybe the one that stands out the most, obviously with dementia they all have cognitive issues, so that's one of them. They have thinking problems. And it's really not that much different with a Lewy body patient than with a non-Lewy body as far as the thinking problem. Maybe a little different in the sense is that before you see significant problems with thinking, you may see some personality issues. You may see some balance problems. And what Lewy body essentially is, and the way it's named is based on what you do when you cut open the brain after someone's dead. There's these Lewy bodies in there. They're also associated with Parkinson's disease. So basic Lewy body is kind of a mix between Parkinson's disease and Alzheimer's disease. It's one of the most difficult types of dementia to treat when it comes to the behavioral problems, the psychosis, the agitation. What's really important to understand when you listen to me, because you might think, well, why might my approach be different? Well, there are very few doctors that work with advanced dementia patients, very small percentage. In the state of South Carolina, where I had the largest practice in the country, from Wilmington, North Carolina, to Hilton Head, South Carolina, to Columbia, South Carolina, which covers, I don't know how many square miles, probably 1,000 square miles, I was the only referral. I took care, I had a unit of 30 patients for a prolonged period of time, and I took care of 28 to 30 patients, usually 7 days a week. In 1 year, I went in every day, 365 days in 1 year, because the other doctors that were in the hospital were not comfortable with this patient population. The other reason I went in is because typically Medicare pays for it, and to really get someone under control, you need at least 10 consecutive days to make adjustments to see them. So if I was treating someone on an outpatient basis, like Liesel's father, who had significant behavioral problems, I would even try to do it because it takes so many adjustments and so much fine-tuning. On the other hand, I know from looking at his medication group, it would not be what I would use. However, I can tell you, some people would look at some of my patients and the medication and say, well, wow, why'd they use that? Maybe he experienced a bunch of things. This is the best I could come up with. But let's talk about a few of them. She sent me the list. They include a drug called Vivitrol, which in the United States is called Clonazepam. This was kind of fun for me because all these names are different than they have in the United States, so I had to look them up. Clonazepam is also called Klonopin in the United States. In South Africa, it's called Vivitrol. Another one is called Donepezil, which is Aricept or Donepezil here in the United States. The third one is called Celexa, which is basically Celexa in the United States, or Citalopram, which is generic. The other one's called Carbilev, and Carbilev is Sinemet, which is a Parkinson drug that we have in the United States. And then the last one's called Sulpiride, which is an antipsychotic that we don't even have in the United States. So those are the 5 medications that she said that he was on. Now, in the big principle, remember, a patient with dementia, whether it be Lewy body dementia or Alzheimer's dementia, is like a boat that has holes in the bottom. And the goal is to plug all the holes. Because if you think about a boat and you plug one hole, the boat's still going to sink because there's 4 other holes. And when I talk about holes in the bottom of the boat, I'm talking about neurotransmitter systems or neural networks. These networks work off all different neurotransmitters, different chemicals. So I found that the more you boost, the more neurotransmitters you can boost in the brain, the better the dementia patient does. Now, my approach is extremely unique, and you might say, why do I have this approach that no one else seems to use? Well, basically, the understanding of treatment of dementia comes from teaching institutions. I was trained as one of the top teaching institutions in the United States. What they teach you in an academic institution is what the studies show. And they tend not to go past the studies. In other words, if a study hasn't been done, they don't really promote the concept. And the problem is there are very few studies done on advanced Alzheimer's patients with a combination of medications. So the studies aren't out there. Well, my approach wasn't to do what the studies say. My approach was to do what I could do for my patients, to try to be as aggressive I could with something that wouldn't hurt them and see if it worked. And seeing so many patients, so you imagine 25 to 30 every day, then my goal was to do what I could do with safe medicines I'd used in other areas of the brain and see if they made any difference. And what I found was they made a profound difference in many cases. In fact, I can say that over time, when I had the people that came in the hospital, and understand, if someone makes it into the hospital for dementia, they are having significant problems. Either can't get out of bed, agitated, paranoid, screaming, yelling, not sleeping, but they're causing a significant disruption either at the nursing home, the assisted living, or at home. So these people are in really, really bad shape. And my position was, if I didn't get them under control, they were going to end up just like Liesel's father, laying in bed and just dying laying in bed. And believe me, that happens all over the world, that patients with advanced dementia end up in bed dying because they're over-medicated, because they can't be put under control. I once had a doctor ask me, she was a psychiatrist, and she said, I've been getting dementia patients, and these really agitated ones, the difficult ones, the late stage, she says, can you get them under control? Because I'm having a lot of trouble. And I said, it's easy to get an agitated patient under control. You put them to sleep. The skill is getting a patient with dementia who's having paranoid agitation and aren't doing well to get them to be awake all day and calm. And I can say that in my patient population, over 5 to 6 years, 90% of the time, 90%, those patients would walk out sleeping all night, awake, energetic, smiling, holding the hands of the family member they were swinging at before they came in. Now, the other 10% typically were somewhat sedated because I just couldn't get them under control. But it is possible in the vast majority of cases to get them under control. Now, Lewy body is more difficult because Lewy body is not only loss of thinking, it's also balance problems, it's also visual hallucinations, and they also fluctuate in their presentation. And fluctuate means some days they are better than others days. Visual hallucinations mean they see things. I mean, they see animals, they see people, and they're very real to the person who has Lewy body dementia. The other part of balance problem becomes significant because of the issue of medications we use often can make balance problems worse. So therefore, you're even more limited because of the medications. And then the final thing, as far as the dementia, it's pretty much like Alzheimer's as far as the pattern of memory loss, which I'll talk about on another show. So as far as the medications that we have here, as far as Clonazepam, that's a class of medications called benzodiazepines. I avoid those completely. Basically, a third of our admissions to the hospital was because a person with dementia, and doesn't mean just Lewy body or Alzheimer's, got put on a benzodiazepine because what they do is they immediately calm the patient, but they do it at the cost of alertness, energy, whatever memory they have left. So it will calm them, but it will also take away from their quality of life. And often what will happen, especially with the longer acting one, the shorter acting ones, Clonazepam is a longer acting one, so it might not cause as much, but a very common one is called Lorazepam or Ativan. And what it'll do is it'll calm them, because there's the calming effect, a little sedation, then that wears off and they're even more agitated. And the reason for this is because patients who have dementia who are out of control, they have a problem with the front of the brain. It's called the frontal lobe. The frontal lobe is what keeps me from hitting you if you get me angry. Well, dementia patients, after they start losing memory, it starts moving the front of the brain, and they will hit you. And the Ativan drugs at first calm them, but then when it starts wearing off, it actually makes the frontal lobes work worse, and the patient becomes more agitated. So about a third of our admissions were because they were put on drugs like Klonopin. So I would not use that at all. The next drug is Aricept. It's a foundational drug. I've talked about that on previous shows. I'll talk about it all the time. It's one of 3 drugs we use that raise acetylcholine in the brain. Acetylcholine is critical to the memory part of the brain, but it's also critical to the quality of life, the patient's mood, their appetite, in many different ways. So it's a foundational, which is an excellent choice. The next drug, which is Celexa. Celexa is in the antidepressant class, which I don't really like the term antidepressants. I prefer brain energy or neurotransmitters boosters because these patients aren't technically depressed. They're not emotionally depressed. What they are is they're low on chemicals that the brain needs to feel good. The problem with Celexa is it's really, really weak. I don't even use it in my patients who are adults who aren't that neurotransmitter deficient. Like even if their brain's not that bad, I still don't like Celexa because it's not very strong. What I have found with the advanced dementia patients, particularly in the Lewy body patients, is they need the more activating, the stronger medicines, and they actually sometimes need more of them. And the reason for this is because they're boosting neurotransmitter systems that are low. So if I see a 50-year-old adult who has depression or low neurotransmitters, they still have a lot of theirs left. So they may not need as much medication as a 90-year-old who has very little neurotransmitters left. And you have to understand, this goes directly against everything we think about when we work with older people. With older people, we tend to use less drugs and less volume of drugs, less dosage of drugs, because they have their livers don't excrete as well, and their livers don't break them down as well, and their kidneys don't excrete as well. So technically, they shouldn't need as much medication. But what I have found with the dementia patients, that their natural neurotransmitters are so low, they sometimes need more. So you'll look at a patient I'm taking care of on a much higher dose of a brain energy medicine than the average doctor. Now, I don't just start them in a high dose. I work them up and look for side effects that are very easy to observe. And once I see the side effects, I lower them. But I found they need a lot. So I would expect a person on Celexa with dementia to not be getting much benefit at all. And then the next drug is Sinemet. Sinemet is something that we use for Parkinson. So I assume that Liesel's father is on Sinemet because he has some Parkinson's symptoms that go along with Lewy body dementia. I don't believe in chasing the Parkinson symptoms with Sinemet. Again, I'm not saying this doctor shouldn't have done that. I wasn't there. But I don't use Sinemet in my patients who have Lewy body because it usually doesn't work by studies. It doesn't show it even works. And one of its common side effects is psychosis and hallucinations. So in fact, if someone comes to me in the hospital on Sinemet, say a person with Parkinson's, and they're seeing things, I try to lower it. So that would be one of my choices. And the final one is an antipsychotic medication. Antipsychotic medication should not be used in dementia patients unless it's a last resort because they can cause an increased risk of death. However, the study that showed that was not a really good study. So in most cases with significantly demented patients, I end up using antipsychotic medications, but I use the weaker ones, and I end up using them at the lowest dose possible to achieve my goals. So probably 50% of the time, I will not be able to achieve my goals without using antipsychotic. And in that case, my favorite is Seroquel because it has very little of the Parkinson problems. It has a lot less problems in it, and it's much more relaxing. So in summary, if you have a person that comes in with Lewy body dementia, and I can say I've seen hundreds of them, and I do get them under control. In the worst case scenario, they're about probably more like 20% end up sleepy because they just don't respond the same. But I would have used Effexor, which is a much more activating antidepressant. I would have used it at significantly high dose to wake him up, to get him out of bed. I also would not have used Klonopin. If he needed to sleep, I would have used Trazodone in the proper doses. If it's given right, it doesn't make him sleep during the day, but it makes him sleep all night. I also would have added Namenda, which works with Aricept to be neuroprotective. I believe in the combination. Even at early Alzheimer's or early dementia, but definitely at late dementia, I believe in using Namenda. And I also would not have used any kind of anti-Parkinson drug. And if I needed an antipsychotic to get him under control, I would have used Seroquel. However, before I would use Seroquel, I would use a mood stabilizer. And my 2 favorite are Depakote and Keppra. And I would have tried those first and see if I got them in control. And if I didn't get them in control, I would not have stopped them. I would have added Seroquel to it. So for Liesl, if you're listening, basically, I can't say if this is the best your dad can have. I can just say I would have tried a different approach. And thank you for joining to the show. Please go to to alzheimersmd.org. Join us, become a member, join our team, tell your friends about it. The goal is to get a message about a new approach that I know works for a significant amount of Alzheimer's patients. See you tomorrow night.